Hi, this is Dr. Vinash. Welcome to this video in which I simplify all the antimicrobials for you. This video is going to be a long video, so I recommend you taking frequent breaks in between. You should complete a topic, go through that topic from your standard textbook, be 100% sure you have understood it. If not, and you have a doubt, shoot a message to me on my WhatsApp and I will be there to help you out. And then you resume back at the place you left off. Try to finish this video in smaller bits and pieces. Let's start with the concept. We are talking about antimicrobials. A microorganism has attacked a human being. We want to kill the microorganism without killing the human being. So, don't kill human cells, kill the bacterial cells is our mantra for this section. How do you kill a cell? Well, if it was to kill a cell, we could have given any general poison. The human would have died, the bacteria would have died. We want to specifically kill the bacterial cell. So we need to find out the difference between a human cell and the bacterial cell. Like for example, the outer membrane of the human cell is a cell membrane, whereas the outermost layer in a bacterial cell is a cell membrane and a cell wall. Human beings do not have a cell wall. If we can somehow make a medicine that can stop the synthesis of cell wall, that can disrupt the cell wall, only the bacterial cells will die. And since we human beings do not have any cell wall, our cells will remain practically unaffected. That's how we came up with the concept of penicillins, cephalosporin, vancomycin and teicoplanin. Simple. Another difference we found out is the fact that even though we and the bacteria both make proteins, we do protein synthesis, the machinery required to make protein synthesis is different in bacteria and in human beings. Well, the concept is going to remain the same. DNA will get converted into mRNA, mRNA will form proteins in the protein factories, protein synthesis factories, which are ribosomes. But the type of ribosome is different in human beings and in the bacterial cell. In human cell, the ribosomes are said to be 40S, 60S and together they form the 80S ribosome. The 40S is the small subunit, the 60S is the large subunit and the total ribosome is said to be of 80S. Whereas in bacteria, the small subunit is a 30S ribosome, ribosome. The large subunit is a 50S ribosome. Whereas the combination is a 70S ribosome. So the total protein factory is 70S in case of bacteria. If we can somehow make a medicine that selectively binds to and stops the protein synthesis by interfering with 30S, 50S or 70S ribosomes and not bind to 40S, 60S and 80S ribosomes, we would have achieved our target of killing only the bacterial cells. Here, we will be discussing medicines such as erythromycin, tetracyclines, chloramphenicol and aminoglycosides. Simple. The next difference we have found is the fact that human beings used preformed folate. We use preformed folic acid. There are some bacteria who make their own folate by a specific pathway, by a specific mechanism. Simple. If we can somehow inhibit that pathway, we would have successfully inhibited or killed the bacterial cells without killing human cells. And here we are going to target this pathway of making folate by using medicines such as sulfonamides and cotrimoxazole. And last but not the least, the DNA replication in human beings and the bacterial cell is slightly different. Human beings are eukaryote, we have chromosomes and we have enzymes called as topoisomerases, which are completely different from the bacterial enzymes called as DNA gyrase and topoisomerase 2. So if I can make a medicine that works on DNA gyrase and topoisomerase 2, we could have easily targeted bacterial cell without harming the human cell. And this is where medicines such as ciprofloxacin and its congeners, fluoroquinolones, would come into picture. Now, having this in mind gives you a clarity of which all targets we can achieve. Try to target the cell wall, try to target the protein synthesis, try to target the folate synthesis mechanism, and DNA replication. Let's have a look at the first one, the first mechanism, try to target the cell wall. Let us first understand how a gram-positive cell wall is made so that we can understand the mechanism of these medications. Inside the bacterial cell, synthesis of cell wall starts. So cell wall is actually outside the cell, but the synthesis starts inside. It starts off with units called as NAM and NAG. N-acetyl glucosamine, that's NAG, and NAM is N-acetyl muramic acid. Both these substances join together. If you also notice, below NAM, N-acetyl muramic acid, are 5 dots. These 5 dots represent 5 amino acids. This is a small amino acid chain, 5 amino acid chain. This unit is then thrown out of the cell membrane. Outside the cell, just outside the cell membrane, many such units accumulate. Getting it? Then these units are joined to each other by a process called as transglycation. So NAM NAG dimer joins to NAM NAG to NAM NAG to NAM NAG, forming long strands of these NAM NAG combination. Of course, this is one line of the many such layers which are present above, below, right, left and center. Everywhere they are present, and that gives the bacteria its typical cell wall. Now there is a problem with this concept. The concept has a problem. The problem is these lines are separate. To make the cell wall stronger, you need to interlink these lines, these chains of NAM NAGs, right? And that's where that amino acid, 5 amino acid chain comes into picture. Okay? An enzyme called as transpeptidase, which is also known as penicillin binding protein, helps us with this particular process. The process is called as transpeptidation. During this process, one amino acid is lost from each chain and a bond is formed between adjacent chains of NAM NAGs. So now what was just a single line becomes a 3D structure of interlocked chains of NAM NAG units. Simple. And that's how the cell wall gets its strength. Let me give you a better look at these mechanisms. The NAM NAGs will be joined together by a process called as transglycation. Okay? The penicillin binding protein or transpeptidase enzyme is responsible for joining the amino acid chain. The 5 amino acids are in a specific sequence. The sequence is L-alanine, D-glutamate, L-lysine, D-alanine, D-alanine. That D-alanine is an important component. Okay? Simple. I hope you're getting everything till here. Now, what you also have to remember is there are some special carriers called as bactoprenol. It is their job to bring these units outside and help them in linking. Now, what we are interested in this, what the penicillin binding protein does. The penicillin binding protein does this. See, it breaks one amino acid from the 5 amino acid chain, and then it links the third amino acid, L-lysine of one to D-alanine of other. And that's how the 3D structure is made. This is a section of a gram-positive cell wall. The structure that I just described, the bacterial cell wall, is a structure called as peptidoglycan. Observe how huge is the peptidoglycan layer. Outside the cell wall, there's a huge layer of peptidoglycan. Of course, there are associated teichoic acid and lipoteichoic acids and many other small proteins, but the most important component of bacterial cell wall here would be the peptidoglycan, made up of NAM, NAGs and the cross-linking between these structures. On the contrary, if you look at the gram-negative bacteria, you will realize that the peptidoglycan here is a pretty small layer, and there is an outer membrane which is made up of lipopolysaccharide and many proteins. You would also be interested to know that there is a space between the cell membrane and the peptidoglycan layer called as the periplasmic space. Plus, there are many proteins, like even on the outer membrane, there will be proteins called as porins, which allow substances to diffuse inside the cell. Simple. So, porins are kind of the channels that are present on gram-negative cell wall. Easy enough? Now, this would be a comparison between the two, but this is much more of a schematic representation. On your right hand side is the gram-positive cell. Observe, the cell has a cytoplasmic membrane just like the gram-negative one, but look at the difference. The gram-positive one has a very thick peptidoglycan layer, no outer membrane layer, no lipopolysaccharide. Whereas the gram-negative one has a very thin peptidoglycan layer, an outer membrane and outer lipopolysaccharide. Simple. So, let me ask you a question. Imagine you are a cricketer. You have a ball in your hand and you want to throw at the peptidoglycan. Where will you be able to hit better? On the gram-positive or on the gram-negative one? Of course, on the gram-positive it's thicker, it's easier to hit. Similarly, if I give penicillin, where will it find penicillin binding protein easily? In the thicker one, not in the thinner one. And hence, the medicines that I am describing work better on gram-positive cells. The first medicine I am describing is called as vancomycin. This is a glycopeptide antibody with amazing efficacy against methicillin-resistant Staphylococcus aureus, Streptococcus viridans, Enterococcus species and Clostridium difficile. So all the deadly bacteria, vancomycin can knock the teeth out of these bacteria. The bactericidal action is more positive on gram-positive cocci, Neisseria, Clostridia and diphtheroids. Now, these are the important points that you need to remember from vancomycin. It is not absorbed orally and therefore it has to be given IV. It is widely distributed. It penetrates the serous cavities, inflamed meninges, and it is excreted unchanged by the glomerular filtration with a lifespan of around 6 hours. Okay, simple enough, easy to understand till now. So, what are the salient side effects of vancomycin? We can remember it as NOR. It is nephrotoxic, so be careful in kidney disease. It is ototoxic, so be careful there also. And then it is known to cause something called as the red man syndrome. This is a syndrome caused by intense sudden release of histamine. The patient has chills, fever, urticaria and intense flushing. He is literally red in color and that's why it's called as the red man syndrome. So where will we use it? Well, use it for MRSA, methicillin-resistant Staphylococcus aureus. Even for surgical prophylaxis against MRSA, we use vancomycin. For Clostridium difficile, it is the second line drug of choice. It is also used in serious skin infections, soft tissue infections, skeletal infections, usually caused by gram-positive bacteria, and for empirical treatment of bacterial meningitis. Vancomycin can be a potential short answer and I want you to be 100% prepared with this and I hope you will be. This is where you take your first break. Open your textbooks, be 100% sure you have understood vancomycin and if there are any doubts, please let me know. After you finish, start exactly here and I am going to teach you beta-lactam antibiotics. Go finish vancomycin and be back here as early as you can. Cool. Now that you are here, I presume you have already finished vancomycin. You have understood the general idea of antimicrobials. Let me help you out with beta-lactam. The beta-lactam antibiotics are the antibiotics which have a typical beta-lactam ring. The one in red box here is the beta-lactam ring. You don't have to draw it in your exams. You just have to know what is a beta-lactam antibiotic. This is how the antibiotic works. It goes and fits into the transpeptidase enzyme. That's why it was called as the penicillin binding protein, an enzyme that binds to penicillin. Actually, beta-lactam antibiotics are penicillins and cephalosporins. Both of them inhibit transpeptidase enzyme. And if transpeptidase enzyme is not there, do you think the cell wall can be made? Not possible. So when beta-lactam antibiotic is there and the bacteria is trying to divide, the cell wall is not formed. We call it CWD forms. Cell wall deficient forms appear. And the interior of the bacterial cell is always more concentrated as compared to the exterior of the bacterial cell. You know what does that mean? If the interior is more concentrated, water will rush in, because things move from things move from a region of higher concentration to region of lower concentration. Water is more outside the cell, water is less inside the cell. Water will go in. This movement is also known as osmotic movement of water inside the cell, and as the water goes in, the bacterial cell starts to swell, it bursts and it dies. Again, if I am going to inhibit transpeptidase enzyme, gram-positive cell wall would be the most important target. That does not mean gram-negative I can't kill. I can, but gram-positive one more. These antibiotics are more active against gram-positive bacilli such as Bacillus anthracis, which causes anthrax, Corynebacterium diphtheriae, which causes diphtheria, all different types of Clostridia, so gas gangrene is covered here, Listeria and Spirochetes, Treponema pallidum and Leptospira, both of them. So syphilis is covered and leptospirosis is covered here. Some gram-positive and negative cocci are also killed. Staphylococcus, Streptococcus, Neisseria, they are all easily killed. Bacteria don't want to be killed. So you know what the bacteria do? They develop a resistance against penicillin. Now there are different ways of getting resistance. The commonest method is making an enzyme called as penicillinase. Represented here by a scissor, this enzyme is actually a beta-lactamase. It breaks the beta-lactam ring. So if a bacteria has penicillinase enzyme, if the bacteria makes penicillinase enzyme and penicillin is given, you know what happens? The beta-lactam ring is broken. And if the beta-lactam ring is broken, the activity of penicillins and cephalosporins stop. And the bacteria can even multiply with penicillin in the surrounding because it can destroy it. Getting it? Now, here comes the important part. Remember the porin channels we spoke about? Remember that because I'm going to give you a very beautiful concept here. The gram-positive bacteria, if it is resistant, it has this DNA, a piece of DNA, the gene coding for penicillinase enzyme, and this DNA gives rise to lots and lots of penicillinase, irrespective of whether penicillin is present or not. What I am trying to say is, if a bacteria has the gene, gram-positive bacteria has the gene, it will make penicillinase, and it does not keep it within itself. It spreads out this penicillinase in the surrounding. Simple, as represented in the diagram here. The penicillinase is everywhere outside. Gram-negative bacteria might also have the same gene, but it only makes penicillinase when penicillin comes. So look at the difference. Gram-positive makes it even when penicillin is not there. Hence this gene is called as constitutive. Constitutive means always active gene. It keeps on making penicillinase irrespective of presence or absence of penicillin. Whereas in gram-negative, it is inducible. Penicillin comes, then the gram-negative bacteria makes penicillinase. Simple. Now, this bacteria is smart. It makes lesser number of penicillinase molecules and it places them strategically at entry point. You know what are the entry points? The porin channels. So, if penicillin comes in through the porin channels, the penicillinase destroys it. So gram-negative is much smarter as compared to gram-positive bacteria in this regard. The second way by which penicillins can become, bacteria can become resistant to penicillins is by changing their penicillin binding proteins. Now imagine this happening. Normally, penicillin attaches to penicillin binding protein and penicillin inhibits penicillin binding protein. Now imagine this has happened. The structure of that protein has changed. The PBP has changed. I hope you are getting it. And now when the penicillin tries to bind it, it can't bind. And if penicillin cannot bind to PBP, to transpeptidase, then how will it work? It can't work, but the penicillin binding protein continues the process of transpeptidation. So bacterial cell continues to be formed. Penicillin cannot stop the action of PBP in this case. The third method is by changing the permeability. Some of the bacteria just don't accept penicillin anymore. If penicillin cannot enter their bacterial cell wall cell membrane, then it cannot act. So these are the three ways by which bacteria become resistant. So let's classify penicillins here, shall we? Acid, see, the original penicillin was penicillin G, but it could be only given injection. No oral formulation was available because acid used to destroy penicillin G. So we found an alternative to penicillin G. It is called as phenoxymethyl penicillin, also known as penicillin V. Got it? Now this was amazing, phenoxymethyl penicillin V, but it could be destroyed by bacterial penicillinase. So we had to search for a medicine, a penicillin that was penicillinase resistant, and we came up with methicillin, cloxacillin, and that was a problem. The moment we made penicillinase resistant penicillin, the spectrum was narrow. Less number of bacteria were getting killed. So what to do now? Let's extend the spectrum of penicillin. Amino penicillins like ampicillin and decampicillin and amoxicillin, and carboxypenicillins like carbanicillin and ticarcillin. The moment we extended the spectrum, they again became susceptible to penicillinase. So we came up with a newer concept. Why not create beta-lactamase inhibitors to give with extended spectrum penicillins? And this includes clavulanic acid, sulbactam and tazobactam. Of course, there's piperacillin and mezocillin, which I forgot to mention. They are uridopenicillins. So this is the classification of penicillin. The one in the box, beta-lactamase inhibitors, they are not penicillin. They have to be given with penicillin. They are suicide inhibitors, which means clavulanic acid will do nothing to the bacteria. But if the bacteria tries to destroy penicillin, bacteria has penicillinase, clavulanic acid will go and attack the penicillinase enzyme. Getting it? Same for sulbactam, same for tazobactam. Actually, the combination of amoxicillin and clavulanic acid is pretty famous. It is called as co-amoxiclav. So this is a very rational combination. It's a fantastic combination. Unfortunately, with penicillins, there are some side effects. Actually, they are very safe drugs. Wherever we inject them, there may be small, pain at the site of injection, especially IM injection, nausea on oral ingestion. And if we give it IV, there is a chance that there might be thrombophlebitis of the injected vein. Sometimes in some people we have noticed that platelets interfere with, the penicillins interfere with the platelet functions. And because of that, bleeding tendencies increase. So these are the local reactions kind of thing. When large IV dose is given, then we get mental confusion, muscular twitchings, convulsions and coma. The important side effect we are worried about is hypersensitivity, okay, which can even lead to anaphylactic reaction, so be careful. As far as our exams are concerned, we are interested in ampicillin. Short answer, see, the side effects, the mechanism of action, the mechanism of resistance is from whatever I have discussed, okay. This is additional point specific for ampicillin. It's active against all organisms sensitive to penicillin G. It kills gram-negative as well as gram-positive bacteria. Gram-negative bacilli such as H. influenzae, Escherichia coli, Proteus, Salmonella, Shigella, and H. pylori are easily inhibited. Ampicillin is not degraded by gastric acid and hence you can give it orally. The problem is food interfere with the absorption. So where will we use it? We use it in urinary tract, respiratory tract infections, in meningitis, in cases of gonorrhea, typhoid fever, bacillary dysentery, cholecystitis, and subacute bacterial endocarditis. It can inhibit H. pylori. And when there are mixed infections or septicemia, a combination of gram positive, gram negative, then we can even try giving ampicillin. This is one of the favored drugs for ANUG, acute necrotizing ulcerative gingivitis, or ANUG. Now there are specific side effects associated with ampicillin that you have to be aware about. Okay. These adverse effects include diarrhea. It changes the gut flora. See, this is an antibacterial. It is not going to differentiate between the good bacteria and the bad bacteria. It can kill our bacteria, the GID bacteria, the good ones, and that changes the milieu, the environment of the GIT. It can lead to super infections also. Ampicillin is known to cause some rashes, and people who have hypersensitivity to penicillin should never be given ampicillin. Avoid it. Amoxicillin is almost like ampicillin. The only difference is it is better absorbed. Food has got nothing to do with absorption. It can be given with food, empty stomach, everything is fine. And compared to ampicillin, amoxicillin gets a higher and more sustained blood levels. And because of this, ampicillin has to be given 4 times a day because the levels are lower. Whereas amoxicillin is only 3 times a day. And also the incidence of diarrhea Amoxicillin, on the other hand, is a close congener of ampicillin. There are like slight differences. For example, the oral absorption of amoxicillin is amazing. Food does not interfere with absorption, and higher and more sustained blood levels are produced, which means the amoxicillin tablets have to be given only 3 times a day, whereas the ampicillin has to be given 4 times a day. Also, the incidence of diarrhea is lower with amoxicillin, so that's a positive. Unfortunately, it is less active against Shigella and H. influenzae, but more active against penicillin-resistant Streptococcus pneumoniae. So it works under certain circumstances better than ampicillin. These are the 2 penicillins you need to know properly. Another question would be, why is the combination of amoxicillin and clavulanic acid a rational combination, or explain co-amoxiclav as a rational combination? You have to make an answer which states how penicillinase can destroy amoxicillin. Sulbactam actually inhibits penicillinase, and hence the combination is rational. I would recommend that you write down this answer and WhatsApp it to me so I can have a look at what you have written. Moving on to cephalosporins. The good news is they don't ask you many cephalosporins in your exam. The bad news is the classification is little difficult, but I have found a way out. The first generation cephalosporins are of 2 types, parenteral and oral. Parenteral includes cefazolin, oral includes cefalexin and cefadroxil. You can remember that all the first generation are 4. Cefazolin, cefalexin, cefadroxil. That's one way of remembering. Second generation is a cocktail. The parenteral one is cefuroxime, cefoxitin. Oral ones are cefaclor, cefuroxime acetyl, cefprozil. There is nothing that I can give you as far as second generation goes. The third generation is easy to remember. It's ime, on or 10. Cefotaxime, ceftizoxime, ceftriaxone, ceftazidime, cefoperazone, cefixime, cefpodoxime peroxetyl, cefdinir. That's the only odd one out. and ceftibutane and ceftamet pivoxyl is the second odd one out. So basically it's IM 1 or 10. You can remember the third one like this. Three tips here. IM 1 and 10. And lastly, the fourth generation is pi. Cefepime, cefpyrome. Simple. There is a fifth generation which is on a roll. Ceftaroline fosamil and ceftobyrole medocaril. Simple. So remember the rules. They don't really ask you cephalosporins in exams, but you still have to know some general rules. Remember them, write them down if you have to, and paste it in your textbook. Orally administered cephalosporins are second and third in line for treatment of UTIs and RTIs. They're never the first line drugs. IV administered cephalosporins are used in treatment of more severe infection like the antibiotic resistant infections. The earlier cephalosporins, means the first generation, have greater activity against gram-positive organism ones. And the gram-negative ones are very limited. You can remember it as PECK. P-E-C-K. Proteus mirabilis, some E. coli and Klebsiella pneumonia. Only these 3 gram-negative bacteria could be killed by first generation, but it was amazing against gram-positive organism. As cephalosporin generations progress, first becomes second generation, third generation, fourth generation, fifth generation, they become more and more active against gram-negative organism. The second generation agents have less activity against gram-positive organism compared to the first generation, but they have greater gram-negative activity. So PECK is there only, plus you have HEN. So PECK-HEN. H for H influenzae, E for Enterobacter, and N for Neisseria. The third generation has an additional feature. It can penetrate the central nervous system. So they are amazing against meningitis. The fourth generation, such as cefepime, are extended spectrum. So they have the same gram-positive activity as first generation, plus gram-negative activity, plus greater resistance to beta-lactamase than the third generation one. So fourth generation is much better with their spectrum as well as their resistance. Whereas the fifth generation ones and the fourth generation ones are active against Pseudomonas. Except the ceftaroline, that does not work against Pseudomonas. Even they are active against MRSA, fifth generation cephalosporins. From the administrative perspective, there is less oral administration and greater parenteral administration as you progress from first to fifth. So you tend to give oral doses for first generation, second generation, but third, fourth, fifth generation we generally prefer IV or IM, so injectables from there. So this spectrum of activity table will help you a lot. Observe how the beta-lactamase stability increases. The activity against gram-positive first decrease, then increases, and gram-negatives, the first, second, third generation gradual increase, fourth and fifth are the same. Simple. Now whatever these past 3-4 slides are, I really expect you to write them down on a piece of paper and stick it in your textbook so that when you are reading it, things are really clear in your mind. Do these drugs, cephalosporins, have some side effects? Yes. The easiest way to remember these side effects are DDT happens. D for diarrhea, D for disulfiram-like reactions. T for thrombophlebitis, H for hypoprothrombinemia, which means there will be bleeding tendencies, A for allergies, P for pain, especially with IM injection, and N for nephrotoxicity, and S for superinfection with fungi. Very easy to remember. Really easy to remember. Now please note, you just can't write DDT happens, give one word and get marks. Please use this mnemonic, refer your textbook, find out the theory behind this, like what to write in exam. Fill up those statements and create your own answers. Like that's what I want from you. So the understanding part is now done. Your next action step is to do the following questions perfectly. So this is where you should pause the video for the second time. Do the classification of penicillins and cephalosporins. Write down the combination of amoxicillin and clavulanic is rationale. Give reason. Difference between ampicillin and amoxicillin, both ampi and amox can be a separate question. You should be able to explain mechanism of action of vancomycin, mechanism of penicillins and cephalosporin is same. You should know the side effects of penicillins, cephalosporins and vancomycin, the mechanism of resistance of penicillins, and good to know drugs would be cefotaxime, ceftriaxone and cefepime. This is what can come in your exam from what I have taught you. Take a break here, go back to your textbooks, go through them thoroughly, find out if there is any doubt, and then we'll take it forward. In the next part, we will talk about something else. So take a break right now, pause it, like really pause it, go finish the topic from the textbook, from the list of questions I have given you, and come back and resume this session. Okay? Very nice. Now that you're here, I presume you have done penicillins, cephalosporins, vancomycin properly. I also hope you have had time to go through teicoplanin. In case you have time, do that additional question. So we have finished most of the drugs acting on the outer layer, the cell membrane, the cell wall of the bacteria, without causing much damage to the human cells. The next session we are going to talk about DNA replication. Okay. Now let's understand the DNA replication first. For the DNA to undergo replication, it first has to uncoil. Okay. The DNA replication starts at a point called as the origin of replication. Here, a specific enzyme called as DNA helicase has been given the job of opening the two strands of DNA. And then some proteins called as SSBP, single-stranded DNA binding proteins, they stabilize